Welcome, everyone. I want to thank Kim and the TESS Foundation. They do such a nice job in organizing everything, and they really rolled with the punches on this one. So thank you for all of these you do. Okay, I'm going to talk a little bit about the phenotype of SLC13A5 clinically. And most of the data that I'm going to talk about has come from the families in a kind of remote fashion. So I've really only met 4 kids with SLC13A5 personally, but I've met many of the families now through email and through their participation in studies. And so the data I'm going to talk about to begin with on the epilepsy phenotype is under submission, but it's not accepted yet as a paper. It is composed really of data we collected through an online questionnaire. And we were able to, with TESS Foundation help, collect data on 23 patients, 11 males, 12 females from 17 different families all over the world. I think the data is pretty good. There are some caveats, of course, to collecting data in this fashion. There was some families that, I should say the questionnaire was only in English, but families responded in different languages. So we did use some translations the best we could. But the data is fairly consistent, so I think it's solid. So I'm going to first describe to you the genetic diagnoses the kids had, the seizure types they experienced, current seizure control, medications they were currently on at the time of the questionnaire. And then I was able to collect EEGs on about 8 patients, and I reviewed all of those. And then I'm going to go over some things I think we've learned from this study and how we might move forward with a clinical trial. Okay. So this is a table with the 23 patients. I didn't really expect you to read all of these, but what you can see is that I divided them up into family groups. So there were multiples of several families, including a family with 3 children. There's a variety of different mutations. They pretty much span the mutations that we are aware of. On the TESS Foundation website, there is a list of all the different mutations that Kim has collected. You can see that most families were able to tell us exactly what the mutation was, and many of them uploaded their actual gene testing. There was one child who looks quite similar to the other children, but we weren't able to find the exact mutation in that child. The neurologist, European country, I'm blanking on which one, just kept writing that the child had SLC13A5, but not the specific mutation. So it's a pretty varied number of different mutations, but it does span kind of what other families that weren't in the study have reported. The kids, 98% of them had neonatal seizures within the first week of life. One child was reported to have seizures starting in the first year of life. So it does seem to be a neonatal onset seizure phenotype. The 3 kids I was able to review long-term EEG studies. So video EEG lasting several days around the neonatal period. It was clear that they were all in status. They were having multiple seizures per hour, but they looked pretty typical for a neonatal seizure, lasting about 20 seconds to a minute. They were frequent, and they were not always obvious to, when the video was working, I could tell that the nurses weren't always picking up on the seizures. They're multifocal, coming from either side. And interestingly, while the background showed a lot of sharps and there was some discontinuity while the patient was having a lot of seizures, it really normalized quite quickly, and the neonatal background just had multifocal sharps, but was otherwise well organized with normal features. And that's going to become a theme of this talk, is that the EEG background actually is quite normal. These are the reported seizure types that the child had experienced. The most common type that most of the kids had experienced was what I would call a generalized tonic-clonic seizure. Now, this is a combination of the ILE epilepsy classification and the parent's description. So you have to take that with a little bit of grain of salt. But so what you notice is that the seizure type are very much motor type seizures. So there weren't a lot of reports of just absence seizures or staring seizures. And there were not many kids that had infantile spasms. And I think this is true from reviewing the EEGs. The seizure counting by the parents, I think, is fairly accurate because they are motor seizures, though that is always in question because the kids do have a movement disorder. And I've been sent quite a few videos of kids now having what appears to me as an epileptologist, a movement phenotype that could be interpreted as a seizure. But whenever I've weighed in with my 2 cents on that, I think it looks like not a seizure, but a movement. They said that that's what their neurologist had told them as well. So there's some agreement that motor seizures are the seizure phenotype. This is interesting to me anyway, in that the patients have a wide frequency of seizures. So this was at the time that the kids were, that the families were filling in the questionnaire. There was one child who was seizure-free off of medications. All the other patients remained on seizure medications, and some parents did write in that they had tried to stop seizure medications without success. However, the seizure frequency varied from no seizures or less than 1 seizure per year when ill to daily seizures. So the spectrum is wide, and there doesn't seem to be any rhyme or reason to this within the families. Now, I don't have large numbers of within families, but even within the same family, some of the kids could be having daily seizures and some could be seizure-free. So I don't think this is a genotype-phenotype correlate, but that is still to be determined. When we asked them what medications the kids were on, there was definitely some movement toward the same medications: phenobarbital, valproic acid, acetazolamide. All were the most common medications, and then a seizure, I think, rescue medication, diazepam or Valium, was also quite common, and then Keppra. But interestingly, when you look at the total number of medications, many of the kids were on multiple medications. And in fact, the orange bars show the patients that were seizure-free. So I use seizure-free being less than 1 or fewer seizures per year. And you can see that phenobarbital and valproic acid, and then Keppra or levetiracetam also had some success in making kids seizure-free. This seems to suggest that possibly these would be good medications to try in your patient if they are not currently seizure-free. Though this is obviously not assurance of that. Since some of the kids, as you can see, 4 of the 9 on phenobarbital were still having seizures. But again, with these small numbers, it's hard to know. Another thing I learned from taking care of Tessa is that, in fact, a medication that has failed in the past can work if you keep trying. So valproic acid has been quite successful recently, where it had not worked 2 times previously. Okay. I reviewed 50 EEGs from 8 patients. The background is actually normal in many, many of the patients. The reports from the local neurologists, I was able to review those as well, and we had pretty good inter-rater reliability. A few of the patients did have some mild slowing, but they still had a very nicely organized background. They had normal sleep architecture when it was captured. There are sharps and spikes, which are markers of an epilepsy predilection, but they're actually not that many. These are not kids that would look like Lennox-Gastaut to pediatric epileptologists. That's in a more severe seizure type where they often have very disorganized backgrounds with lots of sharps and spikes. And we think of them as having an epileptic encephalopathy, meaning that there's some severity to the interictal discharges and the seizures that are causing them to be developmentally delayed. I don't think that is the case here with the number of EEGs I was able to review. Interestingly, a 22-year-old patient, I was able to review her EEG and it was normal, completely normal. She was on seizure meds and did have infrequent breakthrough seizures, but normal EEG background. The seizures in the neonates look like neonatal seizures and the kids are in status. After the neonatal period, however, the seizures were uncommon. So I don't have tons of EEGs, but when they were present, they almost had a generalized appearing high voltage spike and wave with myoclonus. So more data would be needed to see if that really pans out, but you almost would look at their EEG and think that they had some kind of idiopathic generalized epilepsy, which to the epileptologist on the phone call is sort of interesting because you don't typically think of a lifelong seizure disorder that starts in the neonatal period and proceeds to have what almost looks like a idiopathic generalized epilepsy at 20 years of age. So it is kind of a unique phenotype. So what does all this mean? We have a varied seizure type, severity, frequency in older kids. We have a normal EEG background. They don't appear to have an epileptic encephalopathy. I'm going to throw this out as a term I'm using, but I don't really know how else to characterize it. Is that my hope is that the wiring, so meaning like the basic fundamentals of the brain are present and working. I don't know how else you would get a normal organization to your EEG background without that. But there's something abnormal about the way they are talking to each other, for lack of better terminology. It sounds like I'm not a neurologist, doesn't it? But anyway, very non-specific, something's going right, and there's just some subtle problem. And I do think that seizures and EEG may not be the best marker for a clinical trial due to the heterogeneous nature. I do lots of, epilepsy trials, and they would not meet the criteria, many of them, for an epilepsy seizure medication trial. It's almost always 8 seizures over 4 weeks to get you into the trial, and less than half of them would meet that criteria, which is good, but makes it more complicated as an outcome marker. So what would be outcome markers? I think that movement and motor skills would be probably the best outcome marker. Language skills and adaptive behavior skills I'm putting as probably secondary measures. So why do I think movement and motor skills are probably our best outcome measure? Or we can certainly discuss this, but at first glance. So interestingly, we were able to collect Pineland data. Pineland is an adaptive behavior scale where you ask the parents questions about the child, and it can be done remotely. And this is gross and fine motor skills. The blue is gross and the orange is fine. And what you see is that as the kids get older, so the bottom here is age, so they're up to about 190 months. And the score, a better score is better. None of these are in the normal range for age, but you can see that there is a slope upward. It's not amazing, and the kids do seem to plateau a little bit, but they do make some developmental progress with their gross and fine motor skills over time. But again, very abnormal for age. Here is Tessa participating in one of the RET motor rating scales, which I carried out on her to see. And you can see she has this sort of odd wide-based leg movement. Her arms are very moving to keep her supported. Mrs. Nye can run backwards, very impressive. So, oh, sorry. I can't make the slide go forward. Okay, so it turns out the RET motor scale, Tessa was at the top end of it, so we immediately jettisoned that as a good movement rating scale. Since that time, I've tried another motor movement scale, which was a modified version of one that was being used at Stanford by another study group. and it incorporates these tasks that the kids do not have to do a lot of complex cooperative things with. It can be as simple as just a child sitting, and it can be as complicated as them trying to write. And this, at least with Tess and Colton, looks like it's probably a helpful scale. We have a rating scale system. It will all be on video, and it will allow us to get a number score for each component, and then an overall component score. This is language scoring. Sorry, on the left is developmental age, on the adaptive behavior portion for the language, and it's in years, and the bottom is in months. So anyway, the best child at about 180 months was able to get a receptive language score of about 3 years of age, and that was the best we were able to accomplish. So the other thing to note is that, and I think this is true of the kids I've met, that the receptive language tends to be better than the expressive language, and most parents will tell you that the kids understand a lot more than they're able to say. Again, there is improvement over time. Again, not very many numbers, so we'll have to increase the numbers. It seems to me that since most of the kids' language scores are between 0 and 3 years of age, we could use one of the early language scores like a Mullins to use to really assess language. So we are going to use that. The next step that we've been working on developing is a natural history study of, after much back and forth and thought, we're going to do 8 time points over 2 years. It's going to be a combination of in-person and remote. We're going to confirm the EEG data that I've collected in the seizure diary. We're going to focus, though, on adaptive skills, motor skills, and language skills. The motor rating scale is actually videotaped, and it can be done anywhere in the world. So international patients will be included with that score, that scale. And that has been being used successfully at Stanford, so I know that it can be done through the help of the study coordinators and Zoom. The thing that I'd like everyone today to think about, because you all think a lot more about the biochemistry of this disease, is the laboratory studies you would recommend for the patients, if you have any. So please feel free to think about that and email me or talk to me at any time about labs that you think would be interesting to have on the patients. We're also going to do a caregiver quality of life, and yesterday, based on the family conference, we're going to add a sleep disorder scale that Kim Goodsby from UT Southwestern sent me one yesterday that looks nice, and she's using it in a different study, so it won't add too much time, and I don't think it will add any expense, so we'll add that as well. And finally, I want to thank everybody involved with the study. So at Stanford, my colleagues are Dr. Yang and Dr. Spellbrink, who both have had babies within 2 weeks of each other. And then my research coordinators, and of course the TESS Foundation, who has been instrumental in helping me identify all of you who have participated in the study. And I think that's it. Thank you.
Thank you so much, Dr. Porter. I would encourage people again to write any questions they have in the chat box. I think Emily just wrote something in there so that you can sort of see it blinking or see where it is, but please, please do feel free to add questions. I'm going to hand it over to Matthew Bainbridge to talk for a couple of minutes. Matthew, are you there?
Oh, maybe I have to stop. I stopped share. Hopefully that allows him to snag it. I saw Matthew earlier. Oh, there he is.
Matthew, can you hear us?
I think he might have stepped away.
Okay, well, maybe we can sneak him in a little bit.